Prop 63 reappropriation.
Brenda Graylish again, DHCS. Through a spring finance letter, as mentioned here, we're requesting a reappropriation of $1.9 million in unexpended Mental Health Services Act funds. How we would be using those funds is threefold. We are seeking to clean up our client and services information system data. So this is a legacy system that came over from the former Department of Mental Health. It's been in play for over 15 years. And so, we had experienced some challenges in the beginning from the transfer of getting data reported to CSI. We've got that resolved, but it's in what's called the data migration zone because it doesn't meet security or basic standards for DHCS to come into the DHCS environment. And so we've brought that into the DHCS environment now, and now the next step for us is to actually clean up those data so then we can start using it to report on our performance outcome system. So similarly, one of the second things that we want to do is get our data collection and reporting system. So it's our Mental Health Services Act data collection and reporting system, DCR data on full service partners. It's still in the DMZ, or that data migration zone. So, so we're looking to get that out with these funds as well. And then finally, using these funds to do some website redesign because our website can be a little challenging to navigate, so we would like to use some of these funds to be able to make it a little bit easier to navigate, especially as we're looking to post the data for the special terms and conditions and the performance outcome system. I think there was one other question.
What was the
original intended use of the funds? Yeah, so directly from the language, the intended use was for DHCS to provide technical assistance with stakeholder groups during the transition. So at that point in time, the transition from DMH to DHCS, and then to also develop outcome measures and performance metrics, improvement of data sources to strengthen data validity and reliability and related aspects. So this falls right into that. We thought it was one-time funding, so that's why it hasn't been used since the transition. So once we realized it was ongoing funding, then that's why we decided or wanted to seek a reappropriation so that we can actually use it to strengthen our data.
Got it. LAO, Finance, any public comment on this issue, the reappropriation? Seeing none, we'll continue to hold that item open. We'll move to issue 6, drug Medi-Cal. Thank you.
So while Marlise and Don are joining us at the table, I think to acknowledge that what was a fairly unfortunate issue within the drug Medi-Cal program a couple of years ago in 2013 involving some fairly significant fraud within the provider category led us to what was not a really fun time within the department, but led us to a really great opportunity, which is in front of us today, and what both Marlise and Don are working really hard to implement. I know that there was some questions asked by staff in terms of the status of kind of that ongoing investigation and in our A&I system. And so I just wanted to provide that as a context before we talk about the new system that we're in the process of building. We did, and CMS placed upon us a high-risk category for drug Medi-Cal providers, which requires a full physical on-site recertification of every single provider. So we visited all and did field visits for all 547 sites, which is 100% of the provider population. It resulted in 98 fraud referrals to the Department of Justice. 87 providers were temporarily suspended, representing 256 total sites. The 98 referrals that have been made we have 29 actively being investigated. 34 referrals resulted in criminal filings. And then others have been closed due to either lack of evidence or the fact that we can no longer find that provider. I would note that this was not only indicative of a problem within this provider class, but it also revealed both an opportunity and a challenge within our overall audits and investigation staff, and that these providers, in some cases, have either shifted into other provider categories or that they were otherwise linked to other providers within the fee-for-service system. And so that's an unfortunate fact in our program that, expends such significant amounts of funds, is that, for the vast majority of our providers who want to serve our beneficiaries and do it quite well, we have a significant but, intrinsic, set of providers that we are actively looking at. And so I just knew that the staff had asked a question in terms of what we had done to date as well as what we're aware of. And so we do continue to have fairly active and ongoing discussions with both our state law enforcement entities as well as federal entities. So with that, I will turn it over to the fun stuff, which is all about Marlise and Don.
Your numbers were pretty sobering in terms of your findings based on the over 500 field visits. So I wasn't subtracting quickly enough, as you talked about sites that had temporary suspensions. Of the over 500 sites that you visited, how many are remaining functional?
I can...
Even a guesstimate. Half of them, more than half?
It was about half. We halved the provider community.
And so is there a strategy in place? Because with the closure of half, I could be way off track, so feel free to redirect me. And that there was some level of fraud identified. I'm assuming that there were some services being provided in some of those sites, and so my concern would now be access by legitimate,
There were at least 5 actions in which we did not close or temporarily suspend the provider because of concerns around access to care. And so there were a couple that are, and by a couple I mean a handful of providers that were problematic for us that we did not close, but we've, I think, worked with or put on some kind of other administrative action to keep services in place in the community. I think also what it means is that DMC, prior to the approval of this waiver, was a very limited benefit. And so you probably should not focus just on this number of providers, because what we're now kind of looking at more broadly is not just those providers, but how do we fit into an overall continuum of providers that are going to be doing a lot, both different services and more services. And so, again, I look at it as a really amazing opportunity, but it was a fairly significant problem within this class of providers, which we think we have addressed in the most immediate terms, but it has led us into other areas in which we have heightened degrees of concern about.
And given the fact that you're now led into other areas, we are clear that we are talking about fraud. We talked about semantics earlier, as opposed to errors.
We have gone to facilities that are supposed to be pharmacies, and there's nothing there.
Got it. That would be fraud. Got you. I mean, you see what I'm saying? Because it's, and I'm, I'm sensitive and pay attention when we talk about fraud in any public benefit program, but it's also important that we're clear about fraud versus errors, audit-oriented errors, but I got you. Okay. Thank you for the setup, if you will.
Hi, I'm Marlise Perez, and I'm with Department of Healthcare Services, and I get to talk about all the fun stuff. And so really what the waiver is, the Drug Medi-Cal Organized Delivery System waiver, was to take all the issues that we faced with the fraud, and then also ACA implementation, some barriers we were experiencing, and it was really an opportunity to look at our whole system and redesign it. So really what this waiver is a complete redesign of our system. It is a tremendous lift for the counties to be implementing and the state, but we're extremely excited, along with our county partners, our provider associations, and CMS as partners in this effort. So we did receive approval last August, and we began rolling out our technical assistance with our counties through phases. And because we're so large in California and because it's such a big shift, we're implementing in 5 phases. So we started in the Bay Area in about May of last year. Then we moved 2 down into the whole southern region as Phase 2. We kicked that off in about November, and then we just opened up Phase 3, which is our Central Valley, in March. So we'll be looking for the northern counties about the summer for Phase 4, and then our 5th phase is going to be our tribal phase, which will be a little bit further down, just because we have a lot of things that we still need to work with that stakeholder group before we even begin implementation efforts. So we're very excited. We have 9 county plans, one of them being Los Angeles. So we have a big bulk of our population already in play of going through the review process of how they're going to be implementing the terms and conditions. We have DHCS has just approved a few weeks ago our first county, which is San Mateo. So really, really excited about that as well. We still have work to do with CMS. They need to be approving our contract that we have with the counties of how the funds are released, but also how we meet the federal 438 requirements, and those are a lot around access for beneficiaries and protections, which is very new for our substance use field. This is our first waiver. We've never had these federal requirements. We've never had a requirement for a 24-hour beneficiary line, for instance, having a quality improvement committee, all types of an external quality review organization. We've never had that as well. But it's all exciting because it really helps enforce that accountability that we've really needed in our system. And Dawn's going to talk a little bit about this request and the resources that we need to implement all of these provisions. We have received funds from the legislature. I want to thank you. We have technical assistance contract that we kicked off in January of 2016, and we're actually just releasing our TA plan, which is really a lot of the basic tenets of the waiver, which are focused around the ASAM criteria, the American Society of Addiction Medicine, that really provides the framework for our services to ensure that our beneficiaries enter at the least restrictive level of care and then move up and down as needed, but training our field in that, our county partners and then the providers themselves. So that's what some of the training funds are utilized for. We also kicked off our contract in January as well with our external quality review organization that will be monitoring those access and those other 438 requirements. We were also required by CMS to develop a designation for our residential facilities. Because we're utilizing this ASAM assessment, they wanted to ensure that basically what we're doing is assessing that beneficiary to say, you need this level of care of residential 3.1. Well, CMS said, well, how do you know that provider offers those services? And being the first in the nation to have a substance use waiver through this 1115 process, there was no tool. So we worked with our partners at UCLA and our internal staff to create a designation tool. So very excited to say we've already designated 200 of our residential facilities, and we have 351 of these ASAM designations that are already in play. We rolled that out by phases as well, so we could ensure that those early implementers had those residential designations all ready to go. And then last but not least, we always host an annual conference, and so this year we're going to be talking about shifting the SUD paradigm, because this is just a tremendous amount of movement in this field, and so we're just keeping to that theme, and it's really another great training opportunity and time for all of our partners to come together and focus on this waiver implementation. And with that, I'm going to turn it over to Dawn just to give a brief overview of this proposal.
Hi, good afternoon. This proposal is requesting 8 positions for the fiscal oversight and the programmatic monitoring that Marlise has talked about in regards to the DMC ODS or waiver. Some of the provisions of the standard terms and conditions are new, as Marlise talked about, which are the 438 managed care requirements. That's new for our field. As part of the requirements, CMS required that they approve our contract, which has not been done before, as well as reviewing the implementation plans. So we have had and have been working with CMS over the last 3 months for the contract approval and the inclusion of the 438. So we haven't received final approval yet, but we have gone back and forth to make sure that those 438 requirements are part of the contract. Another fiscal provision, these positions will also a unique factor of the waiver is that we've always had state set rates for the counties, and now through the 1115 demonstration waiver, the counties will propose through their implementation plans their own interim rates. And so it will be a county by county basis for those rates. As we talked about when Brenda Graylish was here, we do have some outdated systems. They are in the DMZ, as she talked about. And so as we're looking at our integration of our systems, that's developing, if you can imagine, different rates for all 58 counties, which is a deviation from what we've worked with. So it's a tremendous lift for the system, and it's a tremendous workload both for our IT system, which 5 of these positions are for the EITS, or Enterprise Information Technology System unit, and the other 5 are within my division, or the program side. 3 of the positions, they'll be phased in over 2 years. 5 positions will come in 16-17, 3 positions for 17-18. 3 of the positions are needed in the performance management branch, and that is to oversee the monitoring, compliance, the post-service, post-payment reviews, which is looking at the medical necessity, how the dollars were spent, if you can, for simplicity. Also looking at the EQRO annual reports and developing a triennial review process for monitoring the counties that opt in. The remaining 2 positions will be in the fiscal management and accountability branch, again, developing the cost reports. The cost reports, because of the rate structure and the new services provided under the waiver, the cost reports will also have to be fleshed out. So that's a lot of the workload. Currently, what we've done since we did receive approval, as Marlies talked about since August, is we've really had staff working on identifying areas of need. So these positions, these 8 positions, are really needed to carry out the work when the counties come on board.
Great, and the next piece is, it's an unfortunate situation, but also an exciting opportunity. We do have a tremendous volume of residential facilities that are applying for an initial license, and it's really happening, the reasons are twofold. One is because of our waiver, but also due to ACA, because we do license all residential providers in California regardless of funding source. So unfortunately, it's taking longer to process initial applications because of this backlog. However, we did in the fall start seeing the increase in the applications, so we redirected some staff at the time, but just looking at the numbers again, we're receiving even more and more applications in. So what we're going to do is once again look at redirecting additional staff in order to get the backlog down, because we don't want it to impact the waiver implementation. We don't want to be a barrier to moving this forward.
Do you have any idea what your backlog numbers are now?
It's about 200, and those include our residential licenses, but also our alcohol and other drug certifications, which some counties require providers to have in order to receive government funding. And then also just wanted to, I know you had some questions here about our integration with SUD and primary care services. So in our STCs, CMS had 2 requirements around this area. One was they required us to participate in their Innovation Accelerator program, which they kicked off really focusing on SUD. And one of those areas was the targeted learning opportunities, which we've been participating in this program for about a year and a half. And they really wanted us to be focusing on that physical health integration. So this is a program for states to participate in. So we have been participating and learning from other states about what they're doing. And then also we are required to do an integration plan. And so we had a requirement to have an initial integration approach, which is we had to solidify in April, which we have done, and then we really, October is really the meat, is going to be an integration plan. So we put those 2 pieces together and have already designed a draft integration plan, and we are going to be working with our stakeholder groups. So we're going to release that draft plan to them in about a month or 2. We're going to have stakeholder meetings, see if they agree with our approach. We're really looking at our other federal partners, SAMHSA, because they have an integration approach that they recommend. And so we want to see, does this work for our stakeholder groups? How would they implement it? And then see if that works for CMS. So we're on track to meet that goal. And then the fourth piece, I'll turn back over to Don.
So there was a question about monitoring utilization on the drug Medi-Cal program, and how we will facilitate monitoring that is through the quality assurance and utilization reviews for the counties that opt in, which will be a contractual requirement. There was also a question in regards to caseloads and why intensive outpatient treatment and outpatient drug-free services have gone down. We're not exactly sure what data you're referring to, but the assumption on our part would be that the claims that we looked at, and they were being adjusted for the numbers that providers that were being affected, as Director Kent talked about, through the drug Medi-Cal fraud, those greater than 250 providers. The assumption is that for those years through 11 and 12 and part of 13, 14, we had a reduction for those claims. And we'll probably see a reduction continuing into the beginning of 14, 15, but then we should see a lift after that.
And as you get through the backlog on the licensure. Is that it? Thank you. LAO. Finance. Public comment.
Madam Chair, Helene Meshar, on behalf of the California Association of Alcohol and Drug Program Executives, I wanted to comment on the backlog of applications and also on the recertification issue. We worked for this last year with Director Kent in smoothing out a process to facilitate the recertification of providers in order to minimize the barriers to access and to provide access to services for people in need. And we are pleased to have worked with the department in straightening that out, and the department really did a good job in addressing some of the needs and some of the concerns and problems that were involved in it, and cleared that backlog very quickly in the last year. And we also have been working with the department in terms of the current backlog for applications for certification, and we find that that's also an access issue, and that now with more and more counties coming online through the waiver, that a priority for us is to get those applications for residential licensing and for all licensing moved through as quickly as possible. So if there's additional resources that could be dedicated for that process, that would be wonderful. Thank you very much.
Thank you. Appreciate it. And again, we're holding all these items open till after May revise. We'll move on to issue 7, substance use disorders, healthcare reform implementation, page 30.
Hi, Don Brager, DHCS. This proposal is requesting to convert 10 limited term positions into full-time positions. 5 positions are within program and 5 positions are within the IT section. With the ACA expansion of ACA and SB1, the positions transferred over to DHCS as limited term, and the workload that these functions, as well as, in addition, there's one new legal position that we were adding to this. The functions that the staff have been conducting for the drug Medi-Cal program since transition have been updating and maintaining the provider databases, processing drug Medi-Cal claims and payments, on-site post-payment, post-service reviews, developing county and direct provider contracts, settling cost reports, and working on the electronic fund transfer project, which allows for electronic transfer instead of paper waivers. This is the workload that staff have been doing over the last 3 years. The workload is certainly not done. As we talked about before, due to the drug Medi-Cal fraud, a lot of the staff were diverted from the drug medical workload to deal with the fraud, and so some of these functions are continuing. So this proposal requests to convert the limited term to full-time positions.
Thank you. LAO or Finance? Any public comment? Seeing none, we'll move on to issue 8, residential treatment facilities, implementation of AB 848.